Hello, we've got an interesting case today. We're going to talk in multiple episodes about restoring this edentulous area as well as the teeth on either side of it. You can see a large composite filling on the second bite, large filling here on the second molar. This video is demonstrating endodontics on a 3-rooted second molar, mandibular second molar tooth, and a 1-rooted second bicuspid tooth. I'm using the real world endo through Brasileir endodontic method. If you want the very best videos, subscribe to DentistryMasterClasses.com. Click on the blue link in the description below. That has a library of all the Dental Minute videos plus many complete comprehensive cases, as well as a library of pertinent articles that you will want to read. So subscribe to DentistryMasterClasses.com if you want the very best material. So this is actually the final result with an implant abutment and crown, and then 2 crowns on the second bicuspid and the second molar. So we're only talking about endodontics in this episode. Here's the before and after endodontics and crown on the second molar, and here's the before and after endodontics on the second bicuspid. You can see here's the apex of the root right here, and we'll be showing the real world endodontic technique by Brasileir. I really like that method. It's a rotary system, a single gutta percha cone fill, and it's very easy and very straightforward. So the first thing is to give a mandibular block, and then anytime you're doing endodontics or anything significant to a tooth, don't forget, give an intraligamental injection. Place the bevel of the needle into the sulcus. Now this is after you've given the block or the infiltration, and you're going to use Sit Nest 4% plain because it's pH neutral. And you're just going to apply steady pressure for about 20 seconds in the sulcus. And if it's a molar tooth, I'll often do it on the facial and the lingual. And that tooth will be dead numb. If you only give a block or only give infiltration, many teeth are not going to be completely numb. So if you want to gain the confidence of your patient, don't let them have any discomfort. And this is a painless injection procedure, and the tooth is dead numb, so they don't feel anything when you're doing the procedure. Doing the same thing on the bicuspid. You can see the large composite filling here. Placing the rubber dam clamp. If you're not using this rubber dam method, watch the video and start using it. It will save you so much stress. It makes dentistry so relaxing because the patient's tongue's out of the way, 99% of the saliva's out of the way, the cheek's out of the way. The patient doesn't have to worry about water in their mouth. You still have an assistant aspirating, but it just takes a lot of the stress out of the way. Use what we call a tooth rest, a bite block, and this rubber dam procedure is very easy. It's a little different than the one you learned in dental school because you're not placing it between every tooth. It's just a long stretch, but watch the video. The dental school technique is fine, but it just takes longer and you're having to deal with those little rubber attachments between every tooth. This one, you just got one at the front and the back. But it takes me literally 15 seconds to place a rubber dam, and oh my gosh, the patient likes it and it's wonderful for you. So this is a 330 carbide burr, and just my access opening, very light pressure. Now once I've made my initial cut into the roof of the pulp chamber, I'm coming back with a coarse football diamond. Because as Alex Flory, the endodontist that taught most of our endo courses at my teaching center in Dallas, the Center for Aesthetic Restorative Dentistry, said, you want straight line access to the canals. Now what that means is when you're using your files or your drills, you want to go straight into the canal. You don't want to have to curve it into the canals. So that's what I'm using this coarse football diamond for. I'm opening this up so when I go into the canals, I'm going straight in. It's called straight line access. See a little bit of bleeding, here we go. So see, I've opened this up so I'm going to be able to go straight into the canals, and we've got 1 or 2 distal canals and then 2 mesial canals. Now this is local anesthesia, and I use Sitness Plain for the intraligamental injection and my first injection when I'm giving a mandibular block or infiltration because they're pH neutral and you don't feel it. Watch that video on how to give painless and profound local anesthesia. It's fabulous, and it will win the patient over because they don't feel anything. Now when I'm numbing into the already anesthetized tooth, I'm using lidocaine, 2%, 1 to 100,000 epinephrine. Now why am I doing this? Just to make absolutely positively sure everything is dead numb. It doesn't take 2 seconds, and just anesthetize straight into the canals. If you're not using this real world system, real world endo system, I think you're going to really like it. Now this is number 6 slow speed round burr, and I'm just cleaning out the canals, cleaning out the roof of the chamber, and you place it, the burr into the chamber with no motion, and then move it up the walls. So you open everything up, again creating that straight line access and getting rid of the roof of the pulp chamber. Now I'm back to my coarse football diamond and just opening everything up so you've got a little cup or a little foxhole that you can work in. Set yourself up so that it's easy once you actually start cleaning out the canals. See, so I've got straight access into the canals. You can see the nerve. Now this is a fine chamfer diamond, and I'm just lightly placing that into the orifice of the canals and just cleaning out, so I'm opening them just a little bit. I'm not putting any apical pressure, just opening it up so I've got good access to the canals. I'm checking this with a straight Endo Explorer, just a little more fine tuning, occlusal reduction, opening it up. You know, it's worth taking 5 minutes and get real good access before you start cleaning the canals. Now this is the armamentarium for opening the canals. I've got number 10 Hedstrom and K-type files. I use Hedstrom files more than K-type because they cut more efficiently. Then you've got the real world endo drill sequence from a 25, 30, 35, 40, all the way up to larger file sizes. This drill right here is invaluable. It's a scout file. What you use this for is finding those little tiny sclerotic canals. I don't know that you can separate a scout file. I never have. And you can, once you've opened the tooth, you can take this scout file, squirt some water or sodium hypochlorite in that area and just start kind of poking on that area, and you'll fall into those canals, and it'll go all the way to the bottom very easily, so you gain access. Then this is a new development. I don't know when Real World Endo came out with this. It's a one file filing system, the EJ02, and it files so that the gutta percha point you use to fill the canal is at 30 with a 0.04 taper, and you just place that in the canal, and because it's squiggly like that, it really cleans it out well. So this is what I use for endodontics. I'll use this most of the time. Sometimes I'll use this, and most of the time before I use this EJ02, I'll take a 35 or a 40 drill and open the coronal part of the canal to that 35 or 40, just so I've got more opening, and that's to contain or hold the water sodium hypochlorite mixture. If you've got just a little tiny opening right there, you don't pool as much sodium hypochlorite. So I'll use as soon as I get access opening, I'll use normally a 35 file or drill and just open the coronal part of the canal so that it creates a little pool that you can squirt the sodium hypochlorite into, and it holds it so you have excellent lubrication when you're filing the canal. Don't ever file a dry canal. Don't ever file a dry canal. Be sure it's lubricated, or you're more prone to separating a file. Okay, so we're first going to measure the length of the canal. And remember, I've reduced the occlusion about 1.5 millimeters or 2. So we're going to measure from the approximate occlusal reduction spot down to the apex of the root, and that's about 17 millimeters. We're going to do that before we do any filing. So I'm measuring the scalp file. So that's about 17 millimeters. And I'm filling this up with 3 parts water, 1 part sodium hypochlorite. Now, many endodontists and other people use straight sodium hypochlorite. No problem if you do that. I was taught this originally when I started doing endo 40 years ago, because this particular endodontist had a sodium hypochlorite accident where it had gone through the apex of the teeth into the mandibular nerve, and it was a problem. And so he said, this guy used 5 to 1, 5 parts water to 1 part sodium hypochlorite. So I have used 3 parts water and 1 part sodium hypochlorite all these years, and it's been highly successful. I think in 40 years I've lost 1 tooth on which I've performed endodontics, and that tooth was split all the way through, and we were just doing a heroic save. So this is a very predictable endodontic technique. I haven't used the real world endo technique all that time, but I have used the 3 parts water, 1 part sodium hypochlorite. So this is the scalp file. All this file is doing is accessing the canal and going to the apical part of the canal. Now, this is a hand file. This is the Hedstrom hand file. Always start with Hedstrom hand files. Why? You want to clean the canal before you start using drills, just in case you separated a file. Now, I've never separated an EJ02. I have separated some of the other real-world endo files, the 25 through 40. And the larger they get, the more likely they are to separate if you go around a curve. So hand file first, because if you've hand filed well first down to the apex with this Hedstrom file, cleaned it out and irrigated it well, if you happen to separate a file, it's probably going to be just fine. You don't have to necessarily try to retrieve the file, because retrieving a file can be detrimental to the tooth. You want to be sure you tell the patient if you do separate a file. But in all these years, if I hand file and irrigate first, you've cleaned out 99.9% of the nerve with the Hedstrom file. And if you do that first and irrigate it out, if you should separate a drill, it's never been an issue with me. I would just leave the file unless it was a big infection or something like that, because you don't want to damage the root. You don't want to perforate the root going after that separated file. So I'm sure there are differences of opinion on that. I'm just saying I've never had a problem with a separated file, because I always file it real well with a Hedstrom number 10 hand file with sodium hypochlorite before I start using my drills. Just filing the depth. Now I'm going to measure. You see that's 0.05, that's perfect. And here I'm doing the second canal with the hand file. These are the Hedstrom I'm using. Measuring that, 0.05 again. Then doing the third one. Now, what if you don't get a good read on your measuring device? There's probably too much liquid in the canal, and so just take your air syringe and just blow it out a little bit. Just clean some of that liquid out, and you should get a good read. Now I'm going with my EJ02. And remember, this is going to, when this is finished, a 30 gutta-percha cone should fit that canal perfectly. So I've opened the apical part of the canal, probably the apical 2 to 5 millimeters, with that 35 drill, size 35. Then I've used I first used my scalp file, then my hand files, then my 35 drill, irrigating with my 3 parts water, 1 part sodium hypochlorite all the way. Now I'm using my EJ02 file. I've never separated an EJ02 file. I suppose you could if there was too much pressure, but what you do when you're using this file, you place it until it grabs a little bit, then pull it up, then place it again until it grabs, and then you eventually get to depth. As you can see, I put it till it just barely grabs and come up, and it goes real quickly. Now I'm going into the other canals. Now what if you go into a canal and it won't go? There's probably a curve in the canal. So what I'm going to do is I'm going to go back with my scalp file, the scalp drill, and be sure I can go to depth. Then I'm going to go use my Hedstrom hand file again and clean out that area and try to remove some of that curve so that this will go to depth. I've not ever had a case that I couldn't go to depth using that technique. Scalp file, then Hedstrom hand file, then back with the EJ02. Now I'm irrigating, I've cleaned all the canals out, now I'm irrigating with the local anesthetic with the 30 gauge syringe. Many comments are made, why are you using local anesthetic in the syringe? It's because of the 30 gauge needle. The 30 gauge needle, it doesn't matter what's in there to irrigate with, it just so happens that a carpule goes in the syringe. And the 30 gauge needle is what I'm after because that will irrigate into the canals. You don't put any pressure in the canals, but the local anesthetic with the 30 gauge needle just rinses out any of that sodium hypochlorite or any of the debris in the canals before I place the gutta-percha cones to take a trial file radiograph. So these are, you can see the blue, they're size 30. We'll take a radiograph here. It's perfect. I'll probably cut that one just a smidge, but these are ideal. Yeah, I'm just cutting that just a smidge off that distal. Now I'm irrigating again with the 3 parts water, 1 part sodium hypochlorite, just to be sure everything is nice and clean. And then I'm going to irrigate that out with my local anesthetic with the 30 gauge needle. Now I want to say this one more time. There's nothing magic about local anesthetic. It just so happens that carpule fits in the syringe that has the 30 gauge needle. The significance is the 30 gauge needle because it fits perfectly into the coronal part of that canal. Now you don't stick it down in there and put pressure on it. You just put it in the coronal part of the canal and squirt it in there, and it just rinses any of that sodium hypochlorite or any debris out of the canal before you dry the canals. Now I'm drying them with paper points, and I usually use 2 paper points per canal. The first one gets the majority of the liquid out of there. You can see the canals here, 2 mesial, 1 distal. Now, this is Endo Sequence BC Sealer. You place the tip of this into the coronal part of the canal and apply a little pressure. I want it to actually go as far into the canal as possible. I want it to go as far into the canal as possible. Now, some people apply the BC Sealer onto the gutta-percha cone. I put it into the canal, and then I just take the 1 gutta-percha cone and place it in the canal. Don't move it up and down or you'll incorporate air bubbles. This is my heating element, and I'm cutting that off at the orifice of the canal, then plugging it. Here comes the second one, BC sealer. You can see I'm putting a little pressure on that BC sealer. So I want it to go down as far as I can into the canal. Then I'm removing the gutta percha cones, the coronal part with my heating element, then compressing them with a plugger. This is IRM, and you mix it pretty thick. You don't want it sticky, gooey. You want to mix it pretty thick, and what you do is just put the powder, some extra powder, on the mixing pad with liquid, and the assistant spatulates that and mix a little blob, and then she takes that little blob, puts it in the powder that's still on the mixing pad, and just like you're mixing dough, just pulls that extra powder into that little blob, and it makes it thicker. You don't want it to be sticky when you place it. And this is the plugger, and then come back with a wet cotton tip applicator. Now we're going to the second bicuspid. You could do the endo on both of them at the same time. I normally do one tooth and then the other unless they're two single-rooted teeth. If they're two single-rooted teeth, I'm probably going to do them both at the same time. Now I'm coming back with fine chamfer, just access opening. Again, I want straight line access. You can see that old leaky filling was into the nerve of the tooth. So I'm taking my measurement, which is 18.8, irrigating with 3 parts water, 1 part sodium hypochlorite, then just anesthetizing the tooth with the local anesthetic on the 30 gauge syringe. Now in this case, the canal was so obvious I did not need to use the scalp file to find the canal. I'm going straight with my Hedstrom file. So we measure with the Hedstrom file. You see that was 0.05 irrigating, and now this is my EJ02. Same thing we did on the molar. Now in this case I didn't need to use my 35 drill, but many times I will. Before I use the EJ02, I want to be sure there's enough of an opening here to hold that 3 parts water, 1 part sodium hypochlorite. You don't want just a little tiny canal, because it'll be harder for that lubricant to get into the canal. You can see how that's well filed. I'm going to take my, here's the tip of the tooth, so apex is right there. Take my trial file radiograph, going to irrigate it out again, and then the local anesthetic is just to rinse out the sodium hypochlorite and water. Then I'm going to dry it with my 2 paper points. Then I'm going to squirt the endo sequence into the canal and put a little pressure on this so that it squirts down into the canal. Then put the file, the gutta percha cone straight into the canal, and then cut it off with your heating element, and then plug it with a plugger. And then come back with the IRM. You want to make this as pretty much as thick as you can. It's easier to work with. And then the wet cotton tip applicator. Reduce the occlusal surface. And now we're going to prep those teeth for crowns. So this is a flame-shaped diamond. This is a coarse barrel diamond. Remember, these are going to be 2 crowns. We're going to come back and place an implant in another episode. I'm going to show you how we did that. Then this is just, again, I was using the fine chamfer diamond for the margins. This is a coarse barrel diamond, and I like to remove about 1.5 millimeters of tooth structure circumferentially around the tooth, and about 2 millimeters occlusally. Be sure the technician has got enough room for the restorative material. Be sure you round all the line angles. So here are the preps. Be sure they draw. Just fine tuning the margins with this large, fine chamfer diamond, checking the occlusion. Need to remove a little more tooth structure. Now another good way to check occlusion or occlusal reduction is take 2 thicknesses of pink wax. Put them in a water bath, just make a little strip and have the patient bite on them. And if you see a tooth indentation in part of that pink wax, that's the area you need to reduce a little more. So that's a handy way if it's hard to see from the side, the occlusal reduction. So now we're fabricating the provisional restorations with bisacrylate. You can look up in the Dentistry Master Classes library how to fabricate these polyvinyl siloxane matrix. Wet the teeth. You want the teeth soppy wet. Now if you've done any composite restorations, be sure you place Vaseline on those composites, otherwise this material will adhere to it. You can see how wet that is. Now when you place this matrix, you don't want to press right on top of the teeth that have occlusal reduction, or it will press too far and you won't have any thickness of material over those teeth. Only press from here around. Don't press on top of those teeth. I'm checking the occlusion.
Got it.
Now I'm taking my impressions. This is reversible hydrocolloid. I'll often use polyether with a custom tray. In this case, I was just taking 2 reversible hydrocolloids impression. It's very, very accurate and very easy, and also a very inexpensive impression. You can see here the margins here. Very accurate impression material. It really won't distort because it softens when it's heated, and once you run cold water or really room temperature water through these channels in the tray, that's what makes it set up. So when it comes out of the mouth, it doesn't stretch, it just pops out. Incredibly accurate. You can see how deadly these margins are. Now I'm going to take a polyvinyl siloxane occlusal registration record and place this only between the teeth that have been prepared occlusally. You don't place it up here between the teeth that have not been occlusally or incisally prepared. If you do, it will cause your bite to be open when you seat the restorations. They'll be high. So only take the occlusal restoration record between the teeth that have been prepared occlusally. Trim that part off, so just the preps. And you also want to trim the sides of that bite. You don't want long sides on the occlusal restoration record. You want just the tips of the prep teeth. Now I'm seating the restorations, the provisional restorations. This is Olympia cement. Now as soon as I've seated the provisionals, I'm going to pop floss through here so the cement does not set up in the interproximal contact. All right, now we're seating the final restoration. So I actually place the implant at the same time I performed the endodontics. But as you know, the implant has to integrate with the bone, osseointegrate, for about 3 months. So I went ahead and did that, but since I've prepped the teeth, I seated the restorations on the second bicuspid and the second molar while we were waiting for the implant to osseointegrate. So here are the crowns, and they're Lithium Disilicate or Emax, and you can go to the link and see how we treat those prior to seating. So now I'm just cleaning them with alcohol, and this is a handy way to carry a crown or a veneer. Just some red rope wax on a cotton tip applicator. You can read that, watch that link, put a little Vaseline on interproximal contacts if there's an adjacent tooth, cleaning that real well with isopropyl alcohol after I've tried it in, a little Vaseline on the interproximal contact, wiping the teeth. When I first take the provisional crowns off the teeth, I'm going to wipe them with isopropyl alcohol with a 2x2 in the mouth. Now I'm coming back before I seat the crowns and wiping them with Tublicid Red, which is just a good cleaner. Just place a little bit of this cement around the margins. Don't fill it all the way up. Back in the day, dentists used to make a hole in the top of the crown to vent the crown so that excess cement could come out through the occlusal surface. We don't do that anymore. It wouldn't be a bad idea, except it would compromise the crown. But you don't want to push real hard. You want to just push steadily and give that excess cement a chance to escape around the margins. There's a whole slew of articles on seating crowns, and you want to give the excess cement a chance to escape. Well, you don't want to fill the crown completely up. Tap, 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 tap your teeth together, open. This is going to be the final restoration after we restore the implant. That's the Dental Minute. These techniques work, and they work every time. If you want the very best videos, subscribe to dentistrymasterclasses.com. Click on the blue link in the description below. That has a library of all the Dental Minute videos, plus many, many complete comprehensive cases, as well as a library of pertinent articles that you will want to read. So subscribe to dentistrymasterclasses.com if you want the very best material.